Yeah, I'd like to thank the organizers for giving me this opportunity for the relaying the relay. Can I just share my slides, please? Can you see my slides?
Yes, ma'am. Your audible and slides are visible.
Yeah. So I'd like to thank the organizers for giving me this opportunity. We know that, and these are my, yeah. So we know that despite the rapid advances in the field of EGFR mutated lung cancer, uh, we do see the emergence of resistance to the TKIs, leading to progression of the disease, as well as the fact that all the mutations, EGFR mutations, are not the same. And as a result of that, the response to therapy differs. And that has been brought out by Dr. Kumar Prabhash as well. Well, we have to think of new therapeutic strategies to address these two issues. Preclinical studies have clearly shown that the dual blockade of the VEGF pathway as well as the EGFR pathway has a synergistic effect, supporting the combination of a VEGFR targeting agent with the EGFR inhibitor TKI. And we know that ramucirumab or Cyramza is a human IgG1 VGFR targeted antibody, but it differs from bevacizumab because it blocks the activation of the VGFR2. And as a result of this, it prevents the binding of all the three ligands, whether it be VEGF-A, C, or D, and thus it has a broader mode of action as compared to bevacizumab. Now it has been combined with erlotinib in this study, and I would like to remind you that erlotinib, at the time of initiation of this therapy, was the only globally approved TKI at that time, and that is how that was chosen to be combined with ramucirumab. And as you can see that, as I've already mentioned, that in preclinical studies, the dual blockade of these two pathways seems to be synergistic. And this relay study was designed to test the efficacy of this preclinical observation, as well as to know the safety of this combination. So the design was, it was a phase 3 global study with key inclusion criteria being stage 4 EGFR mutated patients, especially the exon deletion 19 and the L858R with a good performance status. And of course, the exclusion criteria was the presence of the T790M, any prior EGFR therapy, and brain metastasis. Beyond this, there were the usual exclusion criteria for anti-angiogenic therapy, such as bleeding, thrombosis, and thoracentesis, and the need for a tube. These patients were then randomized to the experimental arm, which was ramucirumab with erlotinib versus the placebo with erlotinib, with disease till progression, treatment till progression. The primary endpoint being the investor assessed progression free survival, and secondary endpoints being the safety, toxicity profiles, overall survival, overall response rate, disease control rate, duration of response. The pre-specified exploratory endpoints were PFS2, which is a good surrogate marker for overall survival, and the biomarker analysis. The stratification factors were, of course, the type of the EGFR mutation and the region, because that is important. Remember, this was a global study. So stratifying for the origin is also important, and the testing methods, that is the TheraScreen or the COBAS. Now, the baseline characteristics, as would be expected, were well balanced between the two arms as regards to certain important points like the smoking status, the disease stage at diagnosis, the type of EGFR mutation, and the testing method. Then it actually achieved the primary endpoint of progression-free survival. And as you can see, that it was a very gratifying progression-free survival of 19.4 months on the experimental arm versus 12.4 months on the control arm, which means that there was a difference of about 7 months. And this is equal to the results, so almost of course that we cannot do cross trial comparisons, but it is almost equal to what we see with osimertinib. Of course, always the situation is raised that the brain metastases were excluded from this study. The hazard ratio reached was 0.5, which meant 59, which meant that there was almost a 41% reduction in the risk of progression, and which was highly significant. If you look at the pre-specified subgroup analysis for the progression-free survival, you can see that all subgroups benefited. What is important here and highlighted is that if you look at the previous studies with all the TKIs, the L858R had a modest benefit as compared to the exon 19 deletion. But in this study, what was extremely gratifying was the hazard ratio was similar in both these mutations, like 0.65 for the exon deletion 19 and L858R was 0.62. So it did show a benefit almost equal to that of exon 19 deletion in this study. The other important is again looking at the PFS by the pre-specified EGFR mutation type subgroup. So if you look at L858R, it's 19.4 months, exon 19 deletion 19.6 months. And you can see that whereas the control arm is concerned, the PFS is almost similar. So you can see that the hazard ratios are both showing that they're almost similar, although this trial was not actually powered to look at the significance for these two types. Next. So the duration of response. So if you look into the right hand side, you can see that the overall response rate and the disease control rate were almost similar in both the arms. But despite this, you can see that the duration of response was significantly better for the combination arm, the experimental arm, as compared to the erlotinib alone, with a hazard ratio of 0.62, which was highly significant. Of course, what is important is when patients eventually progress on the treatment, what can you offer them as subsequent therapies? One of the important determinants of this is, of course, the presence of the mutation or the appearance of the EGFR T790 mutation, which makes them eligible for the third generation TKIs. And you can see over here that in the bar diagram, whether it be the experimental arm or the control arm, the occurrence of the T790 mutation were equivalent, suggesting that both could be equally eligible for subsequent lines of treatment with the third generation TKIs. So this is a very important finding, that the combination does not affect this outcome. Then, of course, important is the pre-specified PFS2. What is important is this does happen to be a surrogate marker for overall survival. The data are immature to actually look at the overall survival data. But despite the censoring rate, which was quite high, you can see that the PFS2 looks better and is significantly better in the experimental arm than the control arm. And this, as I already mentioned in the previous slide, is because these patients were eligible for subsequent lines of therapy, even in the experimental arm. So this is an important indicator that what we could expect about the overall survival, but the data is too immature for the overall survival analysis. If you look at the other concern is always that of safety. And as I said, this trial was actually also designed to know the safety of this combination. There were no new safety concerns which emerged from this combination. But as you can see, both the side effects were actually class related. Although the treatment related side effects was numerically higher on the combination arm, if you look at the discontinuation rates of the study, they were similar in both arms and also similar to the trials of the second and third generation TKIs. So the combination did not lead to an increase in the discontinuation rate despite having an intravenous treatment being added to the oral therapy. Then, if you look at the adverse events of special interest, as I mentioned, that these were class related, especially hypertension, proteinuria, and the abnormalities in the liver enzymes being slightly more on the experimental as would be expected. The two deaths which occurred was one was due to bleeding, but one was unrelated. If you look at the ILDs also, they were similar in both the arms. So, in summary, I would like to say that it met the primary endpoint with the median PFS of 19.4 months versus 12.4 months, which was a hazard ratio of 0.59, which was statistically significant. There was a consistent clinical benefit in the pre-specified subgroups, that is the exon 21. What was a very important outcome of this study is accruing almost the same benefit as the exon 19 deletion, which is actually a far cry from what was seen with all other therapies. So you can see that even in the L858R, the median PFS was 19.4 months, and as opposed to that of 19.6 months with the exon 19 deletion. If you look at the safety concerns, which I've already gone through, there were no new signals with the addition of ramucirumab to erlotinib. As far as the occurrence of the EGFR T790 mutation was concerned, it was similar between the two treatment groups, which meant that you could offer subsequent therapies similar on both the arms. Then, of course, relay is now considered a new treatment option for the initial treatment of EGFR mutated non-small cell lung cancer. Thank you.
Thank you very much, Dr. K Smruti madam. Now we will have a clinical case-based discussion. Does one size fit for all?